I'm so glad to be here with all of you today, and I'm looking forward to talking with you a bit about topics that do relate to aging and memory care and brain health and all of these different things that start to become on our radar as we get a bit older. And so we'll be talking about some different things that pertain to how do we first notice and diagnose memory problems and cognitive changes. How do we distinguish what normal aging looks like from other kinds of conditions, which is kind of a big one that I get asked about a lot. We'll also talk about some of the risk factors and the cognitive pattern that goes along with dementias. Our most common one that we think of is Alzheimer's disease, but there's other types as well. And so we'll talk a bit about that. And then I want to talk a bit about some of the preventive strategies, some of the things we can do now, whatever age we are, or even if we're in the middle of something, to maximize our brain health, whether we're preventing it or intervening early on. So we'll talk about a variety of things today, and I'll try to answer your questions as we get to the end. So our first thing is really recognizing that there is a problem when we come to cognitive changes, and most often an individual themselves notices it, or a family member and is concerned about their loved one. So some of the things that can show up are short-term memory problems like losing keys or misplacing other items, forgetting conversations, forgetting recent events. Maybe things aren't quite as clear when you're putting your thoughts together or expressing yourself, difficulties with attention, challenges with organizing or making decisions that start to show up, or even changes in seeing things correctly, like visual perception or language. And a last one that sometimes we don't think about are personality changes. So if a person suddenly doesn't seem like themselves, that's a good indication that maybe we need to look into what's going on. So often folks come to me with the goal of finding out what is happening and getting an accurate diagnosis. So the process for that is important, and it definitely involves a few steps. So I think it's sometimes helpful to lay out what's a roadmap for that. But one of the things we can think about as being helpful is a multidisciplinary approach. So having multiple specialties participate in your healthcare. So perhaps starting with your family medicine doctor or your primary care physician. That's a good general place to get directed to the next step, especially when you don't know where to go next. But we can also keep in mind that even these other clinical pieces rely on what we know about the brain, what we know about cognitive changes, what we know about aging, that come from basic science and research that's done way in the background. So all of us who have specialty areas in healthcare, we're relying on that information. So I just like to point that out, that there's a lot of background research and information that goes into just these different fields being able to do their work. So that initial evaluation with a general medical provider, as I mentioned, is a good place to start. They may refer you or your loved one to a neurologist for neurological evaluation. And this can help better understand if there's something that's changed with brain function. And is there a need for a memory workup? They may order some blood tests. They may order some scans of the brain. And they may send you for a neuropsychological evaluation, which is where I come into the mix. And so with that, I'll explain a little bit more about our piece, but some of the times that people seek our services are when there's a change in emotions, behavior, or cognition, and under a few different circumstances where we can be helpful. So one is if we see that change and it's not really clear why that's happening and a diagnosis is needed. So that's one of the most common reasons that people come to our clinics for evaluation, is to better understand and get a clear diagnosis. Sometimes there's also something that changes, maybe it's sudden or gradual over time, but it's impacting work or daily functioning. That's another time that you may need a neuropsychologist as part of the workup. Another time is if you see unusual physical, sensory, or movement changes. Those are always indications that you want to get examination with a physician and possibly see a neuropsychologist to understand what's going on. Another instance is if there's lack of improvement while going about the usual medical approaches. So sometimes those indicate that there's something else going on underneath it that hasn't also been addressed, especially if there's cognitive symptoms or these other changes that I mentioned above. But if you have a diagnosis and you've been treating it for a long time, and then after a while we're not seeing improvement or there's a decline unexpectedly, those may be times to get further evaluation. And last one is another common reason people come to us, which might be occurring after, for example, a stroke or a brain injury, where there's a known neurological disease, something affecting the brain, and we need guidance on making functional recommendations. So can I return to work or driving? Or should I keep driving if I'm noticing memory problems? And so these functional recommendations are sometimes another important thing about what we do. So what is a neuropsychological evaluation? Let's break that down a little bit. So first off, neuropsychology is a study of brain behavior relationships. We study the way that cognition works, our thinking skills, but we also study behavior in relation to the brain and emotional functioning. And sometimes we look at motor skills as well as another adjunct of this. So when we are actually testing people, we're thinking about all these different domains related to brain function, not just memory, although memory is the one that we often think about the most. So if you come to our office, we'd probably gather a really good history and talk with you first, or you or your loved one. It helps us sometimes get a second perspective from family members who may be noticing different things than the person experiencing the memory difficulty. Part of it too is you can't always remember what you forgot. And so it may not be easy to report on things that you're forgetting, or maybe you don't know that you're having a forgetfulness problem. And so this is where a family member's input and observations become very critical to helping a person get a correct diagnosis and the care that they need. Attention and processing speed, we also look at that. Executive functions, which just means that we're looking at our complex thinking skills like problem solving, reasoning, judgment, decision-making, these higher level thinking skills. We look at language, the way that we express ourselves and understand information, visual spatial processing, motor, and our ability to carry out tasks that we know how to do, sensory functions, and emotional and behavioral functions. So it's a pretty comprehensive perspective. And we approach it with some standardized neuropsychological tests, which means that we do a lot of paper and pencil testing and interactive sorts of game-like tasks with our patients to better understand how well is memory working. So we may give someone a word list to learn and remember, or read them some stories, or look at pictures. And we're actually objectively looking at, can I learn new information and remember it later, rather than just guessing about it or observing it? So the data that we get from this testing helps inform then the recommendations that we make. So we do an objective measure with these different tasks. So once we've gotten through the evaluation itself, we have to start thinking a bit more about what are some of the things that could be going on. And one possibility is that it's just normal aging. Maybe it's just that we're noticing some shifts and maybe our attention's not so good, or it's harder to think of a word here and there, or you can't remember why you entered a room. But there could be just normal aging reasons that that's happening. On the other hand, there could be something bigger, and it's really hard to sort it out on our own. Most people are not very good at observing that difference and knowing what it's supposed to look like at any new age that they reach. So you might talk to your peers and get a sense of, hey, they're having that too, but you still don't know, am I doing it more or not than someone else my age? So the testing can be really informative in separating that. The testing can also help us distinguish if there's something more going on. If there's something like a mild cognitive impairment, which means that we have more changes in memory or aspects of thinking, more than we would expect just for normal, healthy age. And if that's the case, then we want to understand, is there an underlying neurological reason or medical reason for that? And so further medical evaluation may be needed. So let's first talk about that first scenario. What if it's just age alone? What are some of the things that change and what stays the same? So some of the things that can shift as we go across the lifespan are just subtle declines in our attention, working memory, how well we hold information in mind in the moment, and just that ability to concentrate. Our reaction time and thinking speed or processing speed, those can be a little slowed. So they may not be as efficient as we were in our 20s or 30s. And as we get a little bit older, those can have more notable declines. So those are some of the things that may just be going on in relation to age alone. We also might experience some sensory changes of vision and hearing that are common. Thinking of the word that we want to say, what we call word finding, being able to retrieve or pull out that word in the moment while we're speaking or writing it out. Maybe it's thinking of names and other memory lapses. So sometimes memory aids become an important tool here, regardless of the reason, but those small memory lapses, they might be a normal amount. Small shifts in abstract reasoning or problem solving, there may be less reliance on certain strategies, although there tends to be a higher reliance on wisdom and other kinds of long-standing experience and knowledge. But there might be a shift in how people apply that problem solving and reasoning. So notice that it's not all bad, right? These are some mild things, they're subtle, and they don't necessarily, they don't take away what you know, right? Notice what's preserved. So our intelligence, our vocabulary, and our really what we call our fund of knowledge, our internal knowledge that we've acquired across the lifespan, what we know about our world around us and information that we've gathered, and our knowledge base is still going to be there and tends to keep growing. So we tend to keep adding to that throughout our lives. Comprehension also stays in a healthy range, as well as other things like reading, math, and spelling skills. There's a good ability to remember events that happen in general and your own personal history. So that kind of memory is well preserved. So our perceptual skills, our reasoning skills, and decision-making. Notice that judgment and decision-making remains strong. So there's a lot that's working right, and we wouldn't expect a lot of changes with age alone. So that's important to keep in mind. If we do have some age-related changes, we can start to think about what does that look like? What's happening in the brain and our bodies that makes that happen? And we can first look at the structural changes that show up in the brain. We might see a thinning of what we call the gray matter, or the cell bodies. That does occur. We may have some just expected DNA damage that occurs over time as our bodies are on this planet for a longer period. We may have some reduced efficiency of the neural circuits in the brain plasticity, or that ability to change and reorganize. And just in general, things like oxidative stress take their toll to some extent. There's also some chemical changes that do occur, changes in neurotransmitters, those chemicals in the brain like dopamine, serotonin, and glutamate. We can have declines in these chemicals with aging, and certain areas of the brain involved in memory, aspects of higher level thinking and movement in particular can be affected. But not necessarily that all of our thinking skills are impacted or impacted in a very marked way. So we're talking about, again, those really subtle changes. Genetically, we can also see some declines in expression of genes and the functionality of that. There are some changes that do show up in these different ways. So what's really going to make the difference is not just our age, but what else is going on with us in terms of our health. And so chronic health problems in particular can put us at risk. Diseases of the heart, any kind of heart disease is at the top of the list. And that blood flow in the body doesn't just affect the heart, it affects the brain. So we can have cerebrovascular disease or other changes that do affect the efficiency of getting the needed blood flow and oxygen and nutrition to the cells of the brain. Cancer is another risk factor, and you can see that there's quite a few different things listed here So these chronic health conditions and these common health conditions are really important for us to do what we can to both prevent and manage once we have them. Now, just because you have a condition doesn't mean you can't do anything about it. It's important to keep in mind these are just risk factors, and there are still things that we can manage and often treat on their own. So these respiratory diseases, strokes, diabetes, these kinds of things that we can often prevent and do things to minimize the risk, right? So we can take care of our emotional well-being, we can minimize the risk of things like suicide, but these top risks for cognitive decline and diseases do have an impact if we don't take care of ourselves. So when we think about vascular risk factors, those blood flow factors, those are some of the things that we want to think about the most in terms of prevention. That's going to give us a lot of bang for our buck, so to speak. So things that we can do really are what stand out. There's a lot we can control. We can stop smoking, for example. We can manage high blood pressure. We can manage type 2 diabetes or borderline diabetic conditions. We can manage our weight and work with cholesterol. We can treat things like sleep disorders and sleep apnea. And so these approaches can help us change where we're headed in the future by working with our doctors closely and using a lot of lifestyle approaches to manage our health to the best of our abilities. Now, if we think about the difference between normal aging and other changes that might start to approach what we might be concerned about when it comes to dementia, we want to separate out what these paths look like over time. So if we think about what does the change look like, I mentioned earlier that the changes that we see with normal aging are very subtle. Notice that that green arrow going across shows a very mild change over time. As we get older, these changes aren't very big. So we don't expect a lot of cognitive changes or memory problems just with normal aging. That's not a normal part of aging. We want to keep that in mind. If there's something that's really standing out, there's more going on, and we want to get it investigated. So there may be something that's reversible, some of those factors we just talked about, or there may be something that is a neurological condition that could be progressive if we leave it alone and we don't do anything about it. So some of the things that we want to watch for are cognitive changes that become so noticeable that they stand out to family or friends, or that we notice changes in multiple areas of thinking. And when we have that pattern, that we see that there's changes in multiple areas, especially when we do objective testing in the clinic, but we still have adequate functioning day to day, that mild cognitive impairment or MCI is kind of that early phase where there's still a lot we can do and modify what's going on over time. So we may be able to change the course of it. Notice that the light blue arrow shows a pattern where it stays relatively healthy over time, and the other arrow has a progressive course. So we can not necessarily know which direction this is headed, but we have a lot of ability to intervene and try to keep it on a healthy path. If things do progress and we have more of a neurological disease going on, just by definition, we call that dementia, meaning that we have changes in 2 or more areas of thinking, and we start to see changes that affect day-to-day functioning, so that a person may be having difficulty with driving or working or managing their finances, taking care of daily activities. And there's different stages of dementias that an individual would go through as it progresses over time. So we want to keep in mind that not everything that we're seeing with memory is a dementia problem, but if there is, we want to check it out early so we can intervene early and help make sure that we keep the brain as healthy as possible. So some of the things that we can think about with cognitive impairment and dementia is that not everything does progress over time. And that's why it's so important to get evaluated early on. We do have some progressive dementias. Alzheimer's in that first category is our biggest group. And then there's some other types of dementia with other medical conditions or other neurodegenerative conditions that can occur. But not all conditions are progressive. Some of the things that can cause changes may be non-progressive. Maybe there was a brain injury or a single stroke and a person's recovering from those things. We wouldn't expect that to worsen over time. We would expect improvement, and then finding a new normal. Whereas we may have also another category of more chronic conditions or conditions that go on for a period of time, like an infection, and then they're treated or a person recovers. And there may be a period of time where a person has cognitive difficulties and then it improves. So these sorts of things can be treated and addressed, and knowing what the underlying condition is very important so that we can find our best brain health and cognitive functioning in the future. So if we think about this mild cognitive impairment, as I mentioned, just to clarify that definition again, it means that we have changes in a couple areas of thinking, but we're still functioning independently in daily life. We're not seeing the more notable changes that we see with a dementia pattern. And what's important to point out about this category is that even if an individual gets a diagnosis of mild cognitive impairment, we know that not everyone in this category will go on to develop a dementia or a progressive dementia over time. And that's a really important thing to keep in mind. This is a catch-all category, and it catches people who have both reversible conditions as well as those who may, there may be a subset of those individuals who do progress to a dementia over time. So about 15 to 20% of people over 65 have a diagnosis of mild cognitive impairment. And that percentage is so large, partly because it captures all of those different conditions, not just a single one. We see that the conversion rates to Alzheimer's disease or dementia are about 7% of this category after 1 year and 24% at 3 years. By 6 years, it's 59%. So what's also notable is that the more time that you have this diagnosis, the more there's a risk for it becoming a dementia over time. So the duration of these problems is also somewhat predictive of where it's headed in the future. But that's why intervening again is so important. Dementia, once it's categorized that way, is not considered to be a reversible condition, but there may still be things that we can do to intervene to maximize quality of life, slow it down, and maintain that quality of life at the higher levels rather than letting it progress to the more advanced stages while life is going on. There's also a lot of factors that indicate that there may be some modifiable changes in the brain possible during early stages. And so this mild cognitive impairment stage is the optimal time, or the preclinical stage even before that. Those remain the optimal times to intervene. What we see too is that not everyone does convert to a dementia over time, as I mentioned. And that means that about 25% per year of those with MCI will revert back to a normal cognitive pattern, meaning that they had a temporary change in their cognitive functioning, and now they've normalized. So not every kind of change in memory or cognitive function is permanent. And that's also why we want to work with how we intervene faster. So some of the different explanations for this also, there's a few little technical things that go into it too, is that we might have differences in testing procedures over time. There might be different definitions of MCI. And even, if a person is tested at one point and again at a later point, there may be certain effects that are just due to the testing as artifacts of testing itself. But what's important too is that this low annual conversion rate and the high percentage of people reverting back to normal, right? This really does point out this is our window of opportunity, and there's a lot we can do to intervene. So once again, age is a risk factor, but on its own, it's not sufficient for cognitive changes. It's not going to predict that we'll develop a dementia or a mild cognitive impairment over time. Just because we're aging doesn't mean we'll have memory problems or problems that we need to think about in terms of neurodegenerative conditions. So we know that about 14% of people over 71 have a type of dementia, but notice that's still a smaller percentage than the majority of the population, right? And about 70% of those cases are Alzheimer's disease. So it's our largest category. Nearly 2/3 of Alzheimer's patients are women, and we know that it's more common in women than men. So there is a factor there that we want to keep in mind. Cognitive impairment without overt dementia is an additional 22%, or about 5.4 million Americans over 71. So what are some other risk factors for Alzheimer's disease? One of the factors that we can't control, right, is our genetics. We may have some risk. There are certain genes that matter more than others. One of those is the ApoE E4 gene. And the E4 allele, the specific variant of it, is the one that is the highest risk for Alzheimer's disease. So if you have one or two alleles, rather than one plus something else, this is going to put you at higher risk than if you have no E4 alleles, that variant. So that's one thing we can't control. If there's a family risk of that, it's one thing working against us. Other risk factors are low education level, low occupational attainment, so our work history and education may be predictive to some extent. Family history, as we mentioned, having a risk also does relate back to things that have happened in the past. So if we've had a previous traumatic brain injury, especially a more severe one, that can increase our risk for Alzheimer's later in life. Vascular risk factors, heart disease, or other kinds of heart problems that lead to brain problems, right? Those cerebrovascular problems that might come about because of that. And then behavioral changes in Alzheimer's are more associated with the ApoE4 allele, that particular genetic variant, whereas we see that there's actually a reduced risk of dementia with the ApoE2 allele. So our status with the ApoE gene is indicative of what our risk is, but not a given, right? We can have genetic risk without it being automatic that we'll get a condition in the future. Just like a family member can have a condition and we may or may not develop that same condition, even though we're at risk for it. So with Alzheimer's and other dementias, we know that Americans 65 and older are projected to grow, and we keep seeing that. A lot of that is that we have an older population is aging, and so we're having more Americans moving into these categories, partly for that reason. But we know that about 1 in 10 people over 65 has an Alzheimer's dementia. So if we look at that category, the largest percentage are in the older end of that spectrum, over 75. And we see, again, as I mentioned, that more women than men will have Alzheimer's and other dementias. So what happens in the brain when we have something going on like an Alzheimer's disease pattern? And we can look at the brain health of that, and what it impacts is specific areas in the brain related to memory in particular. So our hippocampus in the temporal lobes and the temporal and parietal cortex, these areas on the side of the brain and at the back of the brain, these are going to be particularly susceptible to the kinds of changes that occur in the brain itself. These patterns of change also show up, especially in conjunction with a neurotransmitter acetylcholine. So if we have neurons that are cholinergic in their connections, they're more at risk than other kinds of neurons in the brain. And so that's why we see this hallmark pattern of change with Alzheimer's disease, where we have a deficit or a change in learning and memory for new information. And we see what we can think of as like a rapid forgetting of new information, whereas a person may forget a conversation that was had and within minutes repeat that same question or make the statement or tell a story again without realizing that they've done so. That kind of rapid forgetting means that they're just not laying down that information in the brain. There isn't a record of it. And so they really don't know that they've told that story before. It's like the first time. And that's because the hippocampus, this area in the brain with memory, is where we lay down new memories. And so we need to have that working to be able to track new information. We can see other changes that relate to other cognitive functions like language. We can have changes in language that we call aphasia, or changes in visual functioning or knowing how to do things that we've done in the past. We can also have changes in behavior like apathy or indifference that show up that are brain related. They are not just due to adjustment or no longer being interested in things, there's actually a brain-based reason for those changes sometimes. Now, in mild cognitive impairment and early Alzheimer's disease, the neuropsychological evaluation, the other reason it's so important is that it tends to be the most sensitive for detection. And so one of our important ways to get at what's going on is to come and do this cognitive testing to get a better idea if there is objective change in memory or other aspects of thinking, because we won't be able to observe that just by looking at it on a day-to-day basis. Now, when we say it's one of the most sensitive and specific, we mean that it's usually going to be more sensitive to picking it up than an MRI scan or a brain scan. And it may be more sensitive than other kinds of tests that a general practitioner or your neurologist can order. So this is an important part of the workup, and that's why it's typically included. So some of the types of changes that we see with memory in particular relate to declarative or episodic memory when it comes to Alzheimer's disease. We can have changes in verbal learning and delayed recall. So in other words, something like learning a story now and then learning it, trying to recall it in about 20 or 30 minutes. Notice that that's actually similar to what we do with conversations, that we have little snippets that we share, right? We might talk about a story or we might explain a narrative. And then later we try to remember what we talked about with someone. And so that helps us get at this real world experience of, is someone remembering conversations and more of a narrative? We can also have changes in learning more informational types of things, like if you were to try to memorize a list. And so it's looked at in multiple ways when we do the testing. We also see changes in language. So there may be changes in being able to name objects, being able to find words, especially that more semantic aspect of language that has to do with our knowledge base. And things like cognitive flexibility tend to change as well. So our ability to adapt and see another way to work with something or approach a problem differently, being able to switch gears, so to speak. These are some of the areas of thinking that have shown the greatest sensitivity when we differentiate Alzheimer's disease from normal aging and other dementias. So there is a very specific pattern that goes with it on testing that we look for, and we can use that pattern to help clarify what's going on for a given individual. We also don't like to overlook learning and memory for visual material, even though we may not use that quite as much in our daily lives. But memory for routes or pictures. This is another way that we can assess that we're not missing something when we size up if memory has changed. The other hallmark that goes with a change in memory with Alzheimer's disease is that there is that rapid forgetting, as I mentioned. So there's a decreased learning, and then it's lost very quickly. So it doesn't get stored for later. It happens in the here and now only, and once you're distracted, it's gone. And we don't see that reminders are beneficial for this particular category once it progresses to a certain point. So we can't remind ourselves about something that was never stored, is the way to think about it. We can also have changes in language. So our ability to remember knowledge or information that was overlearned, even something like drawing a clock and imagining what it looks like, or being able to generate words, being able to think of words and being able to express ourselves and put our thoughts together in an organized way, changes in spatial perception, being able to draw a complex design or put some sort of puzzle together, being able to solve problems or make decisions or use judgment to solve a problem-solving situation that might pertain to even safety on the spot. Those kinds of what we call executive function impairments also can show up. And we may also see subtle neurobehavioral impairments. So there may be confusion, agitation, paranoia, and notably a loss of insight. So it may not be that a family member is in denial about their problem. It may be that they just aren't aware of it. And that's a really common thing that we have to sometimes help families understand, is that the person's not denying it on purpose. Their brain is functioning in a way that they can't be aware of it. And it's just like what I said earlier, you can't remember what you forgot, right? It's not an intentional thing that someone's doing on purpose. They just don't have that brain function to allow them to see that aspect of what's going on. And so that's why having loved ones around becomes really helpful in getting it sorted out. And some of these neurobehavioral changes can also show up as depression. That's sometimes one of the earliest symptoms, although there's lots of reasons a person can go through a depression. If it's unexpected or seems to be persisting and not responding to treatment, as we age, especially, it's worth getting further evaluation. So where do we go from here, right? So treatment and management. So once we get through an evaluation, we want to get that diagnosis, and then we want to help everyone understand what's going on. So knowledge is power. You want to be able to get informed, and just as you're doing today and learning about some of these different possibilities for yourself or loved ones, it can help you navigate through it. It can help you stay healthy so you're not going through it. And it can help you manage it the best you can if it's something that you are facing. So what I find with my patients and my families is often that just learning what's wrong can help reduce anxiety about the unknown and about the future, because now you have a better idea what needs to happen next, and we can start to focus on things that will make a difference and be beneficial. So it's usually a multidisciplinary approach to treatment. Things like medication can be helpful, especially if it's in that range of mild cognitive impairment or it is a diagnosed Alzheimer's disease. These medications are sometimes useful for patients as they do target that acetylcholine in the brain. There's other kinds of medications that are used. We're still learning a lot about things that have really make a more marked impact, but these medications have been used to try to slow the process of the change over time. We want to also treat the co-occurring medical conditions and risk factors. This is most important, because if we have something going on like diabetes or sleep apnea or insomnia or any kind of high blood pressure or heart problem, we want to make sure that that's managed or treated as well as possible. That can do two things. One is it can improve functioning and sometimes reverse the cognitive change. And second is it can help treat that condition so you're dealing with a lot less in the first place. So it's in either case, it's going to maximize your quality of life and reduce the risk of having a dementia in the future. Some of the most important other things that we can do really do relate to things we have control over, our lifestyle and our behavioral approach to things. So lifestyle changes like eating differently, there's the Mediterranean diet and the DASH diet have been looked at as healthy options for managing ways that we can improve brain health and also reduce the risk of dementia. We can also work on things like exercise and doing lots of things that make a difference, like getting a good night's sleep and doing that consistently, or solving things that are in the way of good sleep. And working with those lifestyle changes really are quite powerful. I know it sounds like things we always hear about, but I can't overstate the importance of this category. And the last is more direct behavioral interventions. This might be working with a neuropsychologist or a speech therapist. We provide sometimes cognitive compensatory strategy training. This is something we do in my clinic. We run a mild cognitive impairment group for brain health and cognitive training. And we teach people how to work around the memory problems that are showing up and help them work with their attention problems and use good strategies to manage everything in daily life. And that can make a difference day to day. And that makes a difference overall too in what you can do then to take care of lifestyle and taking care of your health in other ways. So these lifestyle changes, as I mentioned, the other ones that I didn't talk about yet were cognitive stimulation and social activation, but staying cognitively active is protective. And we believe that staying socially active is protective as well. So we really do recommend a good structured daily routine, whether you're preventing cognitive issues or you're dealing with them as they've started to occur. Getting exercise and eating a heart healthy diet. With behavior management, if there's a more pronounced issue, sometimes geriatric psychiatrists can be really helpful. They may be able to assist with medication management or things that help make life smoother for the patient and family members, or just other strategies. So there's things that we can do to help make it easier to live with whatever situation is going on. Those cognitive compensatory strategies I mentioned means that we're working around the difficulty by leaning toward the strengths. So there's usually something working. If there's attention working, we use that as a strength. If the problem solving is working, right? And we start to teach people to take notes in a more efficient way, given what they're dealing with, or use our calendar in a more advanced way to track notes and put reminders, and we may incorporate alarms and timers to do that as well. That can be helpful if there's a lot of medications on the list as well. Exercise is at the top of the list when it comes to behavioral things that we can do and prevention. And so I have a few slides about exercise. I'll probably condense it. But what I really want you to get from this is that this is the number one thing you can do to take care of your brain health, is to get regular exercise. There's strong evidence, and we're seeing this more and more with studies that have come out, that exercise lowers our risk of cognitive decline and dementia. And it starts in young or middle adulthood. So we want to start early and then keep it going. And it's never too late to start, is the other thing that we're learning. It makes a difference. Even if someone's already been diagnosed with dementia, we're still seeing a benefit from physical activity. How much is enough? So moderate exercise is recommended in mid or late life to reduce the likelihood. And at least 4 hours a week was found in a study to protect against cognitive impairment. And so, the more that you can fit in some kind of a routine is important. One of the things we're finding out with exercise too is that it's cumulative. It doesn't have to be all in one chunk. You can sum the amounts across the week and they still count. So if you can do 10 minutes here or 30 minutes there or an hour, right, you can add those up. They don't have to be set fixed amounts of time. And what's also important here is that the type of exercise is not as critical as just doing it consistently. So whether it's walking or chair exercises or some sort of aerobic activity, you want to do what you can do for your health status and check in with your doctor if you need guidance on that, or maybe start with physical therapy or a trainer if it's at the beginning of things. But there's usually almost something always that people can do. It's just trying to figure out how you work with your own start point and then working from there to gradually increase it over time. So with cognitive stimulation, what's important here is that we can really make a difference in our cognitive risk by participating in cognitive activities, leisure activities, and social activities. And so staying mentally active, having a structured daily life is going to be much better for us than just sitting and doing nothing, or becoming having a narrower window of activities or social engagements that we're involved in. So this can reduce our risk of MCI and dementia later in life, and it's also going to be associated with cognitive ability, better cognitive ability in middle age. So we notice that it matters across the lifespan, not just when we get in our older age. With cognitive stimulation, activities that require active learning are going to be most beneficial. So if it's something that we're doing all the time, it may not be that stimulating for us. It may be something that's kind of routine. So we want to have a little bit of novel stimulation mixed in as well. That's going to boost this. So for example, if you crochet, that's great, keep doing it. But you may want to add something to that if you've been doing it for years. And so you may want to have something new that you try to learn, or maybe have active conversations or participate in other games or hobbies or activities to supplement whatever that activity is that you've already been doing. So just a brief explanation too about what cognitive training is, since it's something that's formally offered by professionals, and most people aren't aware that it exists. I'd like to just mention it. So cognitive training, when we think about cognitive rehabilitation, usually we think about that in the context of conditions like a stroke or a brain injury where someone's recovering from something and the brain is healing. But we can also use it in other conditions like mild cognitive impairment, where we don't quite know the status of where the brain is going, but we know that it makes a difference to give people skills and strategies and to help them maximize their brain health. And so we do that through compensatory techniques. This compensation model works better than the research when we look at it of trying to restore the brain back to its original state. We don't get a lot of traction when we try to study the brain in that way. So we use workaround strategies, and there's a number of studies that have shown some benefit with areas of processing speed, attention, complex thinking skills that protected against more like age-related cognitive declines even. Computer-based training is another aspect of things. These might be game-like. In general, these are going to be most beneficial if they transfer to a real-world task. We want to probably keep in mind that games that are, just games and puzzles, these may not have a direct relation to real world. And so there may not be a lot of what we call generalizability. There may not be an improvement in areas that you actually want to see a difference when it comes to memory. And so doing things that are most like real life is going to be the most beneficial. In-person training, this is like something that we offer here. These would be led by a qualified professional. You'd have a defined number of in-person or virtual sessions. The goals are to improve functionality and independence or safety, strengthening cognitive skills by workarounds. And that can, often what I see with my patients is can improve confidence and a sense of being more capable of managing things individually and autonomously. So I'm not going to go through that too much there, but I'll just say that structure and routine can improve functioning in daily life. Using a calendar, using cognitive skills and reminders can be things that anyone can do to help their loved ones. And if additional support is needed, seeking out a professional who can work with you can add another layer to that. And then working closely with your whole team is going to be the best approach for managing brain health over time and taking care of yourselves. So there's lots of things to do here. And here's just a few resources I've listed. Anyone needs those, I'll leave them up there a minute. Some great ones. And I want to just leave a few minutes for questions.